prevalence of NASH did not change dramatically from 12.5% to 14%. There was a 119% increase in the rate of significant fibrosis amongst those patients. The Sanyal paper, published in New England Journal of Medicine just recently, highlights this fact that really F3 and F4 patients in a relatively short time point of 4 years are driving outcomes. And so collectively, we look at this data and we say, Houston, we have a problem. I would look at 2021 as a very positive year for drug development. It's allowed 2 drugs, semaglutide and lanifibranor, to go into phase 3. Those trials are actively enrolling. Madrigal has wrapped up enrollment of their phase 3, at least the registrational endpoint part of the trial. And 2022, we are hopeful to have positive results from that phase 3 work with Madrigal, as well as the phase 2s that I mentioned with Poxel and Norcy, and continued rapid enrollment of the other phase 3s. All in all, I think we're in a good spot from a drug development perspective.
Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. First, please let me be among the first podcasters to wish you and yours a happy new year. And now on to business. Over this weekend, we are offering 3 conversations from episode 64, the third and final episode of our year-end 2021 series, even though it's already 2022. The episodes offer shortened conversations with our opinion leaders. This piece shares our entire conversation with Stephen Harrison, looking back on a momentous year in the evolving history of fatty liver disease and sharing some memories about 2021 and Surfing the NASH Tsunami along the way. This conversation represents a candid, detailed discussion with a major opinion leader on a subject he discusses passionately. So sit back, listen, enjoy, learn, and when you're done, join the discussion on our LinkedIn and Facebook discussion group. And for our 5th and final conversation of the day, Louise and I are here with Stephen, kind of like we were back at episode 3, 19 months ago, not knowing if anybody was listening or any of that stuff, and with Peter Traber, and Yasmin wasn't there for episode 3. So if we had a guest, I don't remember who it would have been. And that was 102 episodes and 40-something thousand downloads ago. Here we are again. End of another year. So when we wrapped up last year, we had a conversation, 3 of us, that kind of started with what's happened in fatty liver land this year, and then kind of what's happened with the podcast and how did that all tie together. So Stephen, since you're not Michael Charlton, but you're better than everybody else, why don't you take 5-7 minutes and do the year in review? What do you think are the important things that happened in fatty liver land this year?
Well, you said it best. I am not Michael Charlton. He is a fantastic friend and a wonderful hepatologist, and he has a way to put things together that very few people can do. And I am absolutely, totally expectant and can't wait to hear what he's going to say at NASH-TAG on, what is it, January 7th, my birthday, 2022. So what a birthday present, right? I get to hear NASH in review from Professor Charlton. Reflecting back, it took some time to just kind of think about where we were January 1st of 2021 and how we're wrapping up the year here at the end of December. There are maybe 5 areas that deserve just a quick touch on, and maybe I'll divide those into 1, call to action, 2, natural history data, 3, drug development, 4, weight loss surgery, because I think we need to focus on the paper that we talked about a couple weeks ago and its implications for drug development moving forward. And then finally, non-invasive tests. And I know you've had a couple discussions about that already, and I'll just briefly touch on it from my perspective. Just going back to the first bullet point, a call to action, the paper by Jeff Lazarus really was instrumental in setting the stage for our understanding of processes and what needs to change at the very top all the way to the bottom and everything in between as far as how we evaluate these patients and how do we help them get through the system to get the appropriate evaluation and the appropriate care that they need when and if that becomes available. I know we've had Jeff on here and we've talked about the paper quite a bit. Jorn was part of it as well. And quite frankly, I'm just surprised that we haven't had something like that before this year. I think it was something that was overlooked and sorely missed. That was an important piece of work that came out that we can set as a foundational level and then build on that in 2022 and beyond.
Can we take a sec before we go on?
Yeah.
What strikes me is that another foundational piece of work was the critical care pathway stuff that Ken was involved with, Kusi. And even Jeff says that it was, I think the phrase he uses, an extraordinary piece of work because it makes practical some of the stuff that Jeff says we've got to get to.
That's interesting because that was my point number B under section 1. So on your call to to action, I had the Lazarus paper, and point 2, I had the Campbell paper on the call to action.
Well, in that case, you weren't wrapping up. Forgive me for intruding. Go ahead.
No, that's okay. That's why we're a team. You're thinking ahead relative to what I was planning on saying. So I was fortunate enough to be a part of that paper as well, and a lot of thought went into that paper. It wasn't just a group of insular, focused liver doctors. It was inclusive of a much bigger audience that allowed for introspection and an understanding of how we go about addressing this unmet need of building disease awareness in the field of NASH. And just reflecting back on that paper today, I was reviewing it again. It's such a rich body of work that it's really built for primary care, it's built for endocrinologists, it's built for gastroenterologists, it's built for obesity medicine specialists. It really is all inclusive. It is foundational. It gives us something to begin to work with. The 2 points I want to take away from that paper are, number 1, we wanted something that was keep it simple, stupid, ready, the KISS principle. And I think that provided that. You could punch holes in any of these algorithms that we come up with, and they all have flaws and they all have faults. But we have to start somewhere. And can we get to the point where we all will adopt a similar message and a similar way of looking at these people at the beginning? And I like the way this one was done, mainly because it drives the negative predictive value of a test. That at the foundational level, the primary care level, is really what we're looking for. We want to exclude the vast majority of patients that we don't need to worry about today. And we need to push forward those that we might have a concern about and further adjudicate them. And as I mentioned in my postgrad course talk at AASLD, we're at the very beginning stages of this. We are not at a 5th generation strike fighter that can identify with precision exactly the right patients with exactly their stage of disease and target them for the exact appropriate therapy. We're not there yet, but we accept where we are, and if we can push a similar message out and get primary care behind us, that will be huge. And my third point under this call to action is really the way that the patient advocacy groups have made a huge step forward in 2021. And you've had many of them on the podcast. Obviously, the work that Donna has done, that Wayne's done, that Tony has done, all have been instrumental in their own right. You mentioned the paper that Wayne talked about publishing, the work that Donna has done on Capitol Hill and NASH Day and all those things. It's just those 3 pieces wrapped together, the Lazarus paper, the Conwall paper, and the patient advocacy groups, I think have really taken this call to action on disease awareness a huge step in the right direction, or as I think it's Armstrong said, one giant leap for mankind. So, I think that's what happened in the field of NASH relative to disease awareness. Now, having said that, we were so far behind that even with that one giant leap, we need 3 or 4 more giant leaps. So we'll use it as a platform to springboard forward into 2022, and hopefully we can add a couple more giant leaps on top of what we've already started.
I agree with all of that. We've come on leaps and bounds. I'd certainly second the patient advocacy side, particularly in their involvement now with the FDA, and also the general sense that I've got this year that we are just questioning where the outcomes are for patients, particularly with cirrhosis. I know Manal, and we've spoken about it again today, it's about keeping people stable, should be now an outcome. If we talk about clinical outcomes, then no deterioration is an outcome. And it's particularly important to the person not to deteriorate. They may not improve, but quality and non-deterioration are personal outcomes. That they do as much as they can to try and maximise their own health, along with others' care professionals. That's been raised a lot. That's gathering momentum and steam. That's where the advocacy groups come in. We obviously have the British Liver Trust here, Children's Liver Foundation, things like that. So there is a lot more momentum to say that we're not happy with achieving a hurdle that is too far for me as a person now. I want to just be stabilised. Everything that's moved forward that Stephen's commented on has been great. We spoke with Ken Cusi. I then went and spoke with some colleagues from King's to 50-odd GPs. Janet Catt was advocating that they put FIB4 on all of their desktops so they can use it even if they don't don't do it automatically. Trying to implement these changes in the real world is gathering speed and momentum, and that's where we are now that we weren't 12 months ago.
And you would have guessed, what I think people believed 2 years ago, guessed, that couldn't happen without drugs. And in fact, I think it's a compliment to this community that people have forged forward as energetically as the community has in the wake of, particularly the crash of Oka. And there are those who acknowledge, Stephen among them, but not hardly you alone, that this disease and everything we know about it will get retro rockets, fire boosters when a drug is approved and comes to market. But even so, there's been a tremendous amount of energy around call to action this year without a drug to do it with. And I think that's unusual, in my experience at least.
So why is that? I think it speaks to kind of a rallying of the troops. It speaks to the quality and number of publications that are coming out in this arena, the attention that those publications are getting through media such as this podcast, such as the patient advocacy groups, the recognition that some of these publications are getting at our congresses, the interest that is being generated through other webinars around the data that's being generated in these studies. Maybe there's a paradox in the pandemic in that it's given people a little more time to reflect on some of the work that's been published, and we've been able to rally around that a bit more. So despite having drugs, we're now able to focus more on the data that has come out. So maybe that's what we're seeing.
I think that's part of it, Steve. And I frankly, had Oka been approved, things might have gone in a really different direction and not necessarily as helpful of one, because a lot more of the focus would have been focusing out from Oka. And as you've commented several times recently, FXRs don't look like the backbone anymore.
Right. We'll talk about that in drug development and the milestones we've achieved there. But since you brought it up, I'll mention it now. The Intercept came out with another press release today. I don't know if you mentioned it on a prior podcast episode or a prior commentary today, but they're delaying the results of the reverse trial. I don't know those results. I don't have anything to do with the data analysis, so I feel very comfortable in speculating that does not bode well for the results of that trial, which coming on the heels of the press release recently withdrawing their drug application from the EMA in the non-cirrhotic population. Again, that's like a double whammy against that particular FXR. Doesn't mean the class doesn't still have a role to play, and I may be completely wrong on the results in my interpretation of this press release today. I hope I am. I don't think it means that the FXR class is dead. I do think they have potential as a combination therapy play. I was reviewing some data recently looking at, I believe it was a patient data meta-analysis of all the studies that have been done, over 6,000 patients involved in the trials, and really getting at what mechanism looks like it's driving the most positive effect histopathologically. And you can break them down into drugs that impacted energy metabolism, inflammation, fibrosis, and bile acids. And the two best in this particular meta-analysis were drugs modulating energy metabolism and bile acids. So we know the FXR class has a major impact on bile acids. I do think there is some data there that is positive if you look at even Intercept's data and others as well. As a monotherapy, it's probably not going to wield a sharp enough axe to leave a big enough impact on NASH or fibrosis directly. But we'll come to that, I think, in a minute when I get to drug development and where we are. Just for the sake of time, let me pivot back to point 2, which is natural history data. And I hesitated to include, there are 2 papers I wanted to include here. One of them is one I published, and I hesitated to include it because I didn't want to necessarily quote my own paper. I do think just for the sake of this particular discussion, it's probably okay to do that. So the natural history data has become a little bit more clear. And I say natural history, I'm including epidemiology data in this a bit. And I will first say that the data that we published in Journal of Hepatology this year in over 600 patients that were prospectively evaluated for fatty liver and NASH presenting for routine colon cancer screening pointed to an overall prevalence of fatty liver of 37% and of NASH 14%. More importantly, the prevalence of significant fibrosis was around 6%, 5.9% or so. The reason why I say that is I want to highlight that paper in parallel with the paper we published 10 years earlier in Gastroenterology Hepatology in 2011 on the same type of patients evaluated in the same clinical scenario, but a fewer numbers. We only had 300 patients enrolled at that earlier time point, where we had a prevalence of NASH of 12.5% and a prevalence of advanced fibrosis of like 2.7%. Why do I bring those two studies up? Because collectively there's over 1,000 patients of prospectively enrolled data. And while the prevalence of NASH did not change dramatically from 12.5% to 14%, there was a 119% increase in the rate of significant fibrosis amongst those patients. And that gets me to the Sanyal paper published in New England Journal of Medicine just recently that highlights this fact that really F3 and F4 patients in a relatively short time point of 4 years are driving outcomes. It doesn't mean that F2 doesn't. It just doesn't do it in 4 years. And so collectively, we look at this data and we say, Houston, we have a problem. We have a significant increase in the prevalence of significant fibrosis relative to NASH, which parenthetically almost mirrors identically the paper Arun published in 2015 modeling the growth projections of fatty liver from 2015 to 2030. We're well on that way. In fact, we're probably ahead of schedule relative to that modeling. So we've learned about epidemiology and natural history. We are better at what we do because of those papers that have been published, and we are more skilled in crafting this call to action, if you will, circling back to point one, on who the at-risk patient population really is. So let me stop there and see what you guys think about those comments.
It's interesting because I brought your two papers up with Manal earlier when we were discussing cirrhosis and the fact that the rate of cirrhosis growth, but also the influence of the pandemic, the lack of diagnosis, the lack of presentation, particularly here in Europe. I'm not too sure how much that has affected the US in the same way of just closing our clinics, absolutely all of that down, FibroScan this down, just people not presenting at all. I'm sure it's not dissimilar, but that year or 2 years lost nearly, and how that impacts this late stage diagnostic population, but also the real need now to stabilise disease at that level and not aim for the moon to keep going on the space and sci-fi analogies. But if we continue to only try and meet the FDA's criteria of a one-stage improvement, that's not enough for the rate of cirrhosis that's building, in my mind. And how do we now support that population? Because not enough hepatologists or specialists like yourself to deal with that. And I thought we could just do an episode or a whole series on surfing the cirrhosis tsunami, because they're the popular podcasts. Because people really are going to see more and more of these, not only in primary care and endocrinology. It terrifies me in that the impact that COVID is having, particularly with your data and the other data. We need to stabilise these people.
Louise, I'm just going to make sure I understand the phrase correctly. So when you said one level drop in fibrosis wasn't enough, you didn't mean we need more of a drop. You meant we need a different way of looking at this, and we need it faster.
Yeah, absolutely. Stabilisation to me is an outcome. If I've got cirrhosis or a disease and it does not progress, that's an outcome. At the moment, do we see that as an outcome? I don't think we do, which is what Manal talks about, which is what Donna talks about, and Wayne. To them, no progression is an outcome. And the rate of severe cirrhosis stage 4, as Stephen's showing, is growing at such a rate that we need to stabilise, because it is growing rapidly around the world.
So, Stephen, we've heard a few comments from folks in this round of interviews and that last episode with Ali Minion that talked about that. Alina made the comment, Alina Allen, that if we're going to wait 2-year studies that prove that somebody drops fibrosis 1 degree, we're going to lose a lot of drugs and lose benefit for a lot of patients. Just flat out statement. When we had Wayne on, Louise was having her anniversary dinner at the Ritz and sending us pictures of her cocktails. You know, Louise, Wayne was diagnosed, 12 years ago maybe? And he said he couldn't be termed cirrhotic anymore, his doctor tells him, because his platelets have never rebounded above 120,000, but he couldn't really be deemed cirrhotic anymore because he's gotten so much fat out of his liver. And that's without drugs. That's just based on diet. So I don't know if we call that stabilized or better exactly, but I know it's good enough. I mean, Wayne's had 10 really good productive years and doesn't seem to show any signs of slowing down.
No, but I think that's true, and I think it's the person's perspective. I know as scientists, as clinicians, and Stephen as a researcher, we go on hard data and evidence. But for Wayne, he describes a great quality improvement in his life as a patient-reported outcome. He's got a better quality of life than he did. He changed his life. His wife was very supportive. He did all of the things that we advocate, and he's holding stable, still waiting for these drugs, and he is driving. He's a driving force. And I also heard Stephen, because I listened to the episode afterwards, and Stephen's comment that platelets very rarely after you've got to rebound, and that's absolutely correct. I've seen them rise slightly, Stephen, in people who we recover from Hep C post-treatment, but never to the normal ranges.
Wayne's story can be replicated hundreds, if not thousands of times, and I can probably think of 10 or 15 patients where that's happened in my own practice. Yeah, the patients feel a ton better. I'm just thinking to Hep C, I'm thinking NASH, I'm thinking Hep B, I'm thinking autoimmune, where we have completely reversed the downhill skid on these patients and not just stabilized them, but that downhill has reversed. And clinically, the albumins have returned to normal. And, improvement of albumin to normal is huge. I don't know if people really outside of hepatology understand the meaning of that. When you have a normal oncotic load within your vessels, you don't leak fluid out of your vessel. This is simple physics. You don't get ascites. You don't get lower extremity edema. In fact, if you're getting edema or ascites with an albumin of 4, something else is going on. We see it the most frequent in alcoholic liver disease, where you have a patient presenting with decompensation to the ED, and they're yellow, they look like the Michelin Man, and they're not eating, and they're diagnosed with acute alcoholic hepatitis and alcoholic decompensation, and they recover after a couple days, sometimes longer, in the hospital, and they're sent home. And that seminal moment, they have chosen to no longer drink. And we see about 50% of the patients actually completely recover. They're still cirrhotic. 2 years later, they're still cirrhotic. 5 years later, they're still cirrhotic by any imaging study or liver biopsy that's done. But functionally, their livers have returned to normal capacity to do their job, and this has given the patient more energy, it's given the patient less comorbidities, and they're able to function. So I agree, to the point where we can show stability of disease in a cirrhotic patient is an endpoint. It is something that's worthy of discussion, and because you brought it up here, I'm going to say it now, that is a key topic of discussion at NASH-TAG.
The two of you just did something really interesting, whether you realize it or not, and you're smart people and you might well, but stability has been defined in every discussion we've had as a medical term that is fundamentally about halting fibrosis where it lives. Right? But the life implications of keeping a patient somewhere, and if you stabilize the disease in the way that we're talking about, you're certainly improving the life, right? And the PR of it, candidly, and Stephen, I might actually break my rule that says I'm not a scientist, I don't talk at that meeting, and make this comment in that discussion. Because if we're only talking about stabilizing the patient, then we're not giving adequate appreciation to the liver's ability to regenerate somewhat, and to the role that the disease plays in the overall sense of well-being and productiveness of the patient. So it's really a much bigger thing than just stabilizing.
Yeah, I agree.
And it's massive for patients. But it's not only massive for patients, it's massive for their families. If you stabilize somebody and you stop them becoming encephalopathic because you add in rifaximin or you stop the SPB or you just stabilize them, the family grow and they get confidence and they can look after that person better. We talk about the patient a lot, but the patient is the sum and the center of that family unit and the people who provide care or that they also provide care for, because there's a number of liver patients who also provide care for other people and their disease state interferes with their ability to do that. So stabilization has not only great potential for the person but great potential for everybody around that person, and improving functionality is a key state of stability and they go hand in hand. That is an amazing thing to watch as a nurse and physicians and caregivers, that just no deterioration gives them so much more confidence. It's very, very underlooked and undervalued. It's absolutely key. So I'm really excited that it's part of NASH-TAG and that side.
And as I move to this other couple of points in the sake of time, I'm just going to leave you with this thought. So on the battlefield, and just speaking from 29 years in the Army, the weapons that we have are not meant to kill somebody. They're meant to maim somebody and take you and your buddy out of the battlefield, because you're not going to leave me wounded on the battlefield. You're going to come get me and you're going to pull me back to safety. In so doing, I took 2 people out of the field of battle that are shooting at me. I wounded one, and I took another guy, maybe 2, out of the picture to help get the other guy to safety. Imagine it in this situation. How many people have we seen that present with decompensating liver disease where they have 2 or 3 people bringing them to the clinic, and they're managing them, they're providing their medications, they're tracking them, they're helping them get out of their chair, they're making sure they're not too encephalopathic to hurt themselves. They're incapacitating not just themselves, but their loved ones. People that probably have to go earn a living are now having to find that they can't go. They're having to take PTO. So there's a significant burden not only to the healthcare system because of that one patient, but to society in general because of the workforce that's being taken out of commission to help manage the loved ones. So we've all been there, but I think this is one area that we don't talk about much.
And should. Why don't you go on?
Yeah, so drug development. And it sounds like you talked a little bit about this already. We had some wins and we had some losses in 2021, but we learned from every one of them. So we first shot over the bow at a large number of patients treated with an FGF21 agonist. In F3 and F4 patients did not go as we would have liked it to. Peg-Belfermin did not succeed in achieving its primary endpoint in either of those studies. However, all is not lost with the FGF21 class. We know that Akero reported out positive data, even in a small subset of cirrhotic patients, as we were just talking about. So what we learned in 2021 is that not all FGF21s are created equal, similarly to how we learned over time about the FXR agonists. So I do think there is hope for this particular class of drug, and not just on liver histology. The data that we're learning about FGF21 is that they are impactful on several of the extrahepatic complications of NASH that we often see in our dysregulated metabolism patients. Impacts on glycemic control, lipids, and even weight loss. So that has to be carefully juxtaposed against an adverse event and safety perspective, and that is why these drugs are being carried forward, and we're generating more data in longer-term trials. We had positive data from a GLP-1 agonist, semaglutide. It was published in New England Journal. Phil Newsom is the first author. We also had positive data from lanifibranor, where Sven Frank and Manal Abdumalik were instrumental in that body of work. So all is not lost. Positive data from many phase 2A trials that are moving forward into phase 2B. We saw our first positive inferences from combination therapy. And I would be remiss to say the one study that we haven't talked a lot about that did not succeed was GenFit's elafibranor trial. And while that trial was not successful, we learned a significant amount about the type of patient we should be screening for these trials, not only from the GenFit phase 3 trial, but from the Golden 505 study, which was the phase 2B trial that came before Resolve It. So I think 2021 was a year of continued learning in drug development, but we do have 3 phase 3 trials currently enrolling. As we look forward and we look ahead to 2022 in reference to drug development, there's a lot of things to look forward to. Paxil has a chimerized PPAR gamma or pioglitazone-like drug that uses deuterium to stabilize the enantiomer that's effective in PPAR gamma pioglitazone, minimizing the adverse events of the enantiomer that is not thought to be effective. That drug has multiple mechanisms. One of the biggest one is it modulates MPC, and that trial is completed enrollment of a decent-sized phase 2B study, and should be reading out in 2021. North Sea has a structurally engineered fatty acid that has completed enrollment of a very large phase 2B trial that will be read out in 2021 as well. And then both Madrigal phase 3s we should be hearing about in 2021. Those are just the highlights of a couple of the bigger ones. Doesn't get into all the phase 2s that we should also hear from non-invasively, and some further refinement of some of the phase 1 data. We'll also get into some combination therapy work as well, and some results potentially with combination therapy ongoing. So I would look at 2021 as a very positive year for drug development. It's allowed 2 drugs drugs, semaglutide and lanifibranor, to go into phase 3. Those trials are actively enrolling. Madrigal has wrapped up enrollment of their phase 3, at least the registrational endpoint part of the trial. And 2022, we are hopeful to have positive results from that phase 3 work with Madrigal, as well as the phase 2s that I mentioned with Poxel and North Sea, and continued rapid enrollment of the other phase 3s. So all in all, I think we're in a good spot from a drug development perspective.
In the interest of time, I've got nothing to add to that. I think that's a pretty complete statement, and there isn't much to add, and there is nothing I disagree with. So, Louise, if you got something, go.
Manal, when we spoke to her earlier, said she would hope that some of the ones who didn't pass and weren't successful get put on the shelf so that we can work them out later, maybe when we have better techniques. Do you think that's could happen?
We've got, Medicrin kind of shelved their program with their FXR class, and then Enanta did as well with their FXR. Both left the door open for potential combination work in the right setting. Again, looking at that meta-analysis I talked about, drugs that modulate energy, drugs that work on bile acids, maybe that's a good combination, and in the right setting, I think there is an opportunity for that as well. And Inyo is still in the game from an FXR perspective as well, and the data I presented at AASLD even points to a potential renal benefit of their particular FXR. So that would be exciting to see if we were able to continue that development there as well. Bariatric surgery paper, we talked, I think it was 2 podcasts ago, or last podcast. I think it deserves just a shout out again on the year-in-review. That paper, I believe, is seminal. It's one that we'll be referring to for quite some time, and it speaks to the benefit of weight loss in the field of drug development for weight loss. If you're able to achieve those types of numbers, you have a good chance of being successful. So I would be remiss if I didn't highlight that particular mechanism for improving histopathology and extrahepatic benefits of this liver disease as well. Let me shift gears to the NITs. So I know Alina Allen and probably many others have talked about where we are with non-invasive tests, what we learned in 2021. I would just like to highlight a couple things. We had Alina on here, and the work that she's doing is absolutely amazing and exciting to see where MRE is going to take us. As I mentioned many times before, MRE gives us a distinct advantage in getting to a non-invasive test beyond the biopsy in cirrhotic patients very, very quickly. And again, hopefully that's a big topic of conversation with the agency at NASH-TAG. We looked at some exciting data coming out with CT1, multiparametric MRI, corrected T1, looking at outcomes measures there as well. So anxious to see where that goes. But here's where it gets interesting. Some of these combination tests that are being developed. We saw MEFIB from Rohit Loomba, which is FIB4 plus MR elastography, and being able to detect the at-risk NASH patient with a high degree of sensitivity and specificity. It was corroborated by some work in Japan. MAST, something Mazen, Naredin, and others, myself included, have been working on, I think has potential. Refinement of FAST using Agile 3 and Agile 4 with FibroScan are also helping to identify these at-risk patients. The use of sequential testing, as highlighted by the Canwall paper and the call to action, will continue to be refined. But the message is clearer in 2021. We need to look at combination tests. There are more tests out there than what I've mentioned today. I haven't spoken about ELF. I haven't spoken about ProC3. I haven't spoken about FibroSpect, FibroSure, LiverFast. There are others out there. Take-home message I think that we need to deliver in a uniform way is at the primary care level, let's use a test with high sensitivity to exclude people who don't have disease. Let's refer those that are indeterminate or positive, have them undergo a more specific test, and see if those patients can then be put into appropriate treatment algorithms. To me, that's become clear. Where we still need to go as we look to 2022 is to have a very frank conversation with the FDA, including the Biomarker Qualification Division, around what it will take to move away from a liver biopsy as an endpoint in NASH treatment trials. And that particular context of use deserves significant discussion. I'm anxious to see where Nimble and Litmus take us as far as all the work, the fabulous fabulous work that's being done there that Quentin Anstey is leading for Litmus and that Arun Sanyal is leading for Nimble. I know Rohit Lumba is doing a significant amount of work with his gold mine study as well. All of these data sets are going to continue to grow, and the data that we're going to glean from them is going to be instrumental in helping us sit down with the FDA to come up with an acceptable surrogate endpoint. What has become clear is that endpoint needs to be adjudicated against an outcome measure and not a liver biopsy. So how do we get there? And I think that's a topic that we're going to dive into in 2022. And so maybe I'll conclude there and turn it back over to you, Roger, and to you, Louise, for further comment.
I agree with everything he said. What he looked at earlier about how many, and the strength of non-invasive tests in a local environment and mobility for some of these, like FibroScan, for a lot of the biomarkers, and combining those in those areas. That allows us not to have 3 people come into clinic with everybody. If we move it, this is where one of the advantages has come out of COVID. We have a lot more telemedicine. If we can perform FibroScans with X, Stephen can see a lot of these patients, for example, over a virtual environment with all of the best data in front to prevent travel. It allows us to use that person in their environment. It stops the cascade of multiple people attending clinic. The time frame. When I was treating hepatitis C in Australia, people would travel 6 hours each way for a half an hour appointment. It's fast, it's scale, it's not something we're used to in the UK, but it is something that the US deal with, and large countries that with remote communities. We have to use the strengths of non-invasive technologies, and that's what I think we have strengthened with not only what we do here, but with the dialogue, but also with COVID may well have pushed that development that much quicker.
That's interesting and makes some sense. One of the thoughts I have is that the faster we go with non-invasive testing, the better we're going to do with the less ambitious medically, but humanely important. Like we talk about the value of stabilizing cirrhosis, right? No one's going to do biopsies to figure out if you're stabilizing cirrhosis unless you're in the middle of a clinical trial and you're forced to. But better use of non-invasive tests means that we can track those patients better, where in the absence of medication, eventually even in the presence of medication, but now clearly in the absence of medication, our goal is to maintain, which doesn't require quite the same level of precision as it does if you're trying to fill a clinical trial at the levels of confidence that you need to, I think. I'm not a doctor. I just kind of watch all this happen, but that's my sense of it. So aggressive advances in non-invasive tests will redound to the benefit of the patient every day, not just in drug development, but in how patients, in fact, can be managed. And I agree with you, Louise, you put that together with telemedicine and the ability to decentralize clinical trials and put FibroScans on trucks for patient care. It's a much more powerful and a much more humanly built or humanly developed or human conceptualized system. And that's the thing we should be able to move on pretty quickly, I would think, if I understand you right.
Yeah.
Stephen, can I just ask you, if we were to stabilise cirrhosis, from my recollection, particularly maybe F3 into that early cirrhotic, if we stabilise at that level and monitor, that does reduce the cancer levels that we experience in the severe F4s. Is that right? So by stabilising an early high fibrosis...
I don't think we know that, Louise. No, I mean, clearly these people would have to be screened for liver cancer indefinitely, even if you stabilize them. What I do think it affords us the opportunity to do is begin to look at chemopreventative therapies, where metformin, statins, even coffee have shown to be effective at reducing the development of HCC. There are a significant number of drugs in development that could continue to enhance our chemopreventative therapies. Some of the drugs, interestingly, that are in development for NASH actually potentially have anti-cancer properties relative to them. So that gets at a whole other look at how to develop these drugs. But I'm not sure. I'm not sure we have enough data to be conclusive in saying that if we arrest stage 4 into a well-compensated state, that we reduce the risk of HCC alone.
Let me, because this is already running a little longer than we had in mind, and I do want to do one more question. Stephen, that was fantastic. It lacked some of the flair and the remarkable visualization of connections that you get with Michael, but in terms of breaking it down and saying, here's what mattered, and here's why, and here's how it goes together, that was just fantastic. Thank you so much.
I couldn't outdo Michael, so I restrained myself from having the flair and the drama that he brings to the table, because he needs to sit on that Bema seat himself.
And therefore, you simply outdid Stephen, which is pretty damn good. We'll take it. Question. We started off down this road 20 months together, three of us. We sat here last December and said, pretty good. We got through a year. We did something. What do you think is the best thing that came out of the podcast this year? And separately, the thing that surprised you most. Brave one, go first.
Yeah, I think that's a tough question. I guess two tough questions to ask. To me, I just holistically, I look at this and I see, I don't know where our numbers stand today with listenership, but I've heard you mention throughout the year that we've had steady increases in downloads, sometimes dramatic increases in downloads. More countries are listening to the podcast. And so I am just super thankful that we were given this opportunity to be a centralized location for delivery of information relative to NASH for patients, for primary care providers, for sponsors, for device manufacturers, for people that develop tests for this disease, for physicians at all levels. This has beat my wildest expectations. So for that, I'm very thankful and grateful and can't wait to see where this is headed. From maybe a surprise perspective, I like how the podcast brings out the real in people. We get to know who they really are. We get to learn the backstories. Maybe the one I'm stuck on the most is Scott Friedman coming on and telling us the life story of the stellate cell. Mm-hmm. Where else are you going to get that information? You're not going to get it in a 15-minute lecture at AASLD or EASL. He's not just going to pull you aside at the meeting and take the time to explain to you his whole career and what happened from when he first sat down with the stellate cell to where he is today. It is mind-boggling to learn that bit of information, and you're not going to learn it anywhere else from except this podcast. So that and the extracurricular activities of many of our speakers, learning their interests and what drives them, it just makes it fun. It makes it interesting to be in this space. It doesn't take anything away from what we do for patient care, but it makes it real when we sit down and say, this is my colleague, but this is also my friend. This is also somebody that I can relate to. And I think that's what's been exciting about this podcast for me.
Okay, Louise, I'm going to claim last word on this one, so you go next.
I know you definitely get the last word on this because the question gets reflected back to you. I suppose for me, I think the strengths that I see in the podcast are the fact that we seem to bring everything to the mixing pot, whether it's patient focus, whether it's nursing, whether it's allied health, whether it's physician, whether it's researcher. For any care pathway or any holistic opportunity, you've got to bring as many stakeholders as possible to the table for that discussion. Whether or not you necessarily agree or don't agree, or you want to chip in or you don't want to chip in, we allow that melting pot to really bubble and carry on. And I suppose the one surprise for me is that we can still have enough to talk about after 2 years. And we're only, as Stephen said, scratching the surface, but we have come on leaps and bounds. And just the wealth of data. I'm not the scientist, I'm not going to produce all of that. And some of it, listening to the stellate cell, I seem to understand it when he explained it really nicely, but if as Stephen says, but I bring a different perspective. Mine's more holistic, mine's more health, mine's more the patient questions that they never want to ask a doctor in the room. So I think it's the strengths that we all bring. But yeah, I'm surprised we can still talk and talk and talk on this topic. And I'm looking forward to talking and talking and talking for the next year.
So, Louise, ironically, we've now got more subjects to cover than we have weeks to cover them. In fact, the stuff coming at us in terms of episodes to put together has proliferated, not shrunk. When we got started, Peter Draper made the comment that podcasts never run more than, 12 or 14 weeks because he wasn't worried about it. And here we are, it's 104 weeks later, and I could give you 3 things to do every week if I had time to organize it or staff to organize it with. I think the thing I like best about this podcast is, and Stephen, it goes back to the thing that surprised you most. By making everybody real, we've made the things we talk about accessible to people who otherwise wouldn't see it quite so organically. You know, when folks talk about this being what they expect coffee tables are like at major medical conferences, or what happens when friends get together, or Ian's comment that I've quoted a couple of times, wrote before he was on, about before this podcast, the only way you could ever get to hear what Quentin Anstey knew was if you could somehow foot stop him by holding a door open so Quentin couldn't leave at a conference. So we've given people all that. And because nobody's particularly in a rush when they come on this podcast, we've given it to them in a very human way. In 105 episodes, we've only had one person who ever came on this podcast to play a role instead of to, I believe in retrospect, to play a role instead of to engage honestly. And that wasn't good, but that's never going to happen again. And Stephen, you know who I'm talking about because I see you nodding. That's just not going to happen again. I think we're well past that. So that's the thing I like best. The thing that surprises me the most is all the different ways in which this podcast is actually being used to educate this community, which is crazy for me because I know nothing. I'm just running this thing. You guys are providing all the content on that level. We've had grad students in third world countries sign on as subscribers, and when we asked why, they said, because my professor told me I have to listen to this to learn about fatty liver disease. That's just crazy, right? Stephen and I know of one drug company where every week they get together, including half the C-suite at least, to spend an hour talking about what did they see on this podcast. I know another company where one of the women in medical affairs is designated to go to the meeting every week and talk about what did we do. So, in a world where information is so plentiful and so easy to find, the idea that we've, and this is really the three of us and everybody who comes on with us, have been able to put this together in a way that people find it so accessible and so valuable.
What that one person really wanted to know, though, Roger, was what the new backdrop is for Louise this week. I mean, that has become the TikTok item, the Instagram news story.
What Bones is wearing this week?
Now that we've seen every room at Manal's house,
we're going to have
What else is left?
But I mean, who else gives you the flair for the eclectic than Louise? I mean, one week it's bones, next week it's fish tanks. It's like the proverbial box of chocolates. You just never know what you're going to get behind the scene.
Absolutely. Well, he's made it real by going live. So if we go live, I've got to be something more than just us.
It's true.
Well, wait till we take this thing to audio video all the time, as compared to just live audience. Stephen, we got to let you go, and this has been fantastic. I just want to thank the two of you so much. I've said this several times. I never knew how burned out I was doing what I was doing until I started doing this, and realized how much fun and how rewarding work could be again. And Stephen, I owe you a debt of gratitude. I'll never repay you. But Louise, likewise. You guys, everybody else, but you guys in particular, make this so much fun and so rewarding. They say it's not work if you love it. This isn't work.
That's great.
That's
great, and you do such a good job at it. I mean, this is your ballywick. This is what you were honed and built for, and you do a great job of moderating and leading and planning and staging and editing and the whole deal. So it doesn't work without you at the helm here. And
yeah, definitely doesn't work.
Louise, you bring a side to the story that is refreshing, that is critically important, and really rounds out and completes the podcast. And I don't know how Roger found you, but I'm so glad he did.
She kind of found me. She just kept posting things in places that I was looking, and finally I said, who is this woman?
I tell you, I'm the gobby nurse, but I will be gobby to get patients seen, screened, and thing. And
there you go.
I've got somewhere to be gobby. And great people to be gobby with, that's all I can say.
Everybody enjoy the holidays. Take it easy. Treat your livers with a certain amount of kindness over the week, but not too much kindness. And we'll see you back on January 3rd, right? Louise, I'll see you tomorrow, but Steve, I think we're good.
Tomorrow.
Okay.
Have a lovely holiday, Steve.
Thanks, everybody. Okay, bye-bye now.
Bye.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. Join me again January 2nd for our full conversations with Jeff Lazarus and separately Andrew Scott.